Welcome. If you're in nursing school, you absolutely know that the newborn assessment is one of those foundational skills you've got to master. So in this explainer, we're going to do just that. We're going to break it all down from head to toe to build up that clinical confidence you'll need for exams and for your future practice. So here's our game plan. We'll kick things off with the Apgar score, that super critical first-minute assessment. Then we'll dive into vitals and the full head-to-toe exam. After that, we'll cover how to assess gestational age and check those important reflexes. And to wrap it all up, we'll hit some key NCLEX prep to make sure all this knowledge really sticks.
All right, let's jump right in. Section 1, Apgar scoring. Now, this is the very first, and you could argue, the most critical assessment you'll ever do. It happens right in the first few minutes of life and tells you so much about how that little one is transitioning to life outside the womb. Think about it. The moment a baby is born, it's a massive shock to their system. So how do we quickly and reliably figure out if they're in distress or if they're handling the change okay? Well, the answer is a simple but really elegant scoring system. And here it is. The Apgar score. The acronym itself is a fantastic mnemonic: appearance, pulse, grimace, activity, and respiration. A score of 2 is perfect for each category. Now, for appearance, you'll often see a score of 1 because the baby has a pink body but bluish hands and feet. Don't panic. That's called acrocyanosis, and it's totally normal while their circulation gets up to speed. A good, strong cry, by the way, usually gets them a solid 2 for both respiration and grimace. So what do these numbers actually mean? Well, this isn't just about getting a score, right? It's a call to action. We do it at 1 minute and then again at 5 minutes. A score of 7 to 10 is great. That baby is doing well. A 4 to 6 means they're having some trouble and might need a little help, like some oxygen. But a score from 0 to 3, that's a huge red flag. It means severe distress and that baby needs immediate resuscitation. Okay, section 2, vitals and measurements. Once we know the baby's stable, our next job is to get that all-important baseline data. These numbers are going to be the foundation for all the care we provide. Okay, when it comes to newborn vitals, order is everything. Seriously, we always go from least invasive to most invasive. That means you count respirations first for a full minute while the baby is quiet and calm. Why? Because if you start poking around with a stethoscope or a thermometer right away, that baby's going to get fussy, their breathing will change, and boom, your respiratory rate is useless. Now, when you look at these expected ranges, a few things might jump out at you. A respiratory rate of 30 to 60? Yep, that's normal. They can even have these little pauses in breathing, called apnea, as long as they're short. And that heart rate? Way faster than in adults, typically 110 to 160. That's why you have to listen to that apical pulse for 1 full minute. No shortcuts. And these measurements, they're not just numbers on a chart. They're critical for tracking growth and making sure the baby is getting what they need. And see that bit about head versus chest circumference? The head should be a little bigger, about 2 to 3 centimeters larger. That's a key developmental sign we keep an eye on. All of this helps us classify the newborn as small, appropriate, or large for their gestational age, which has major clinical implications. All right, on to section 3, the head-to-toe exam. This is where we get hands-on. We're going to do a really systematic physical exam, starting right at the head and working our way all the way down to the toes. This way, we make sure absolutely nothing gets missed. Okay, NCLEX alert. This is a classic, so listen up. You've got these 2 types of swelling on the baby's head. They can look similar, but there's one massive difference: the suture line. Caput feels kind of soft and spongy, and it crosses those suture lines. Cephalohematoma, on the other hand, is a collection of blood that does not cross the suture line. So how do you remember it? Just say it with me. C caput crosses sutures. Got it? Good. Now you're going to see all kinds of things on a newborn's skin, and your first job is to not freak out, and then to reassure the parents. Milia are just little blocked oil glands, no big deal. Mongolian spots? It's super important to document these bluish spots so no one mistakes them for bruising later on. And erythema toxicum sounds terrifying, right? It's just a harmless newborn rash that goes away on its own. Okay, another this or that you need to know inside a newborn's mouth. Epstein's pearls are these little harmless cysts. They'll disappear. Thrush, on the other hand, that's a fungal infection. It looks like white patches, and it needs to be treated. So one is just reassure the parents, the other is time for an intervention. All right, let's do a quick NCLEX check. A nurse sees small, pearly white nodules on the roof of a newborn's mouth. What is this? Let's think it through. Is it on the skin? Nope. So we can rule out A, B, and C. That leaves us with D. Epstein's pearls. Exactly.
Okay, moving on to section 4, gestational age and reflexes. Here, we're really digging into the baby's maturity, both physical and neurological. We'll use a cool tool called the new Ballard Score and then test those primitive reflexes that tell us so much about their brain function. So the Ballard Score looks at 2 big areas. For neuromuscular stuff, we're looking at things like posture. A full-term baby is all curled up and flexed, while a preemie might be more limp. Then for physical maturity, we look at stuff like skin texture and the creases on their feet. You add it all up, and it gives you a really good estimate of their gestational age. This is so important because, as we know, a baby's maturity is directly tied to their health risk. First up, the Moro reflex, also known as the startle reflex. You gently let the baby's head fall back just a tiny bit, and whoosh, their arms should fly out symmetrically. We're looking for both arms to do the same thing. If one arm lags, it could be a sign of an injury from birth, like a broken clavicle or nerve damage. Okay, the Babinski reflex. This one is super interesting because it highlights a huge neurological difference between babies and adults. You stroke the bottom of a baby's foot and their toes fan up and out. That's a positive Babinski, and in a baby, it's 100% normal. But if you saw that in an adult, big trouble. This reflex usually goes away around their first birthday. Next, we have the rooting and sucking reflexes. These are pure survival instincts, right? This is how the baby eats. You stroke their cheek and they'll automatically turn their head that way, looking for the nipple. It's an amazing reflex that's there from birth and then fades after a few months as they get the hang of feeding. All right, let's bring it all home. Section 5, NCLEX prep and clinical judgment. It's one thing to memorize facts, but it's another thing entirely to apply them in a real-world clinical scenario. So let's connect the dots. Okay, you have got to know these lab values for your exams. Look at the hemoglobin, hematocrit, and white blood cells. See how high they are? In an adult, you'd be freaking out, but for a newborn, it's totally normal. And pay special attention to that glucose level. Anything below 40 is hypoglycemia, and that's a problem you have to fix fast. Here is a memory anchor that could literally save a life. If you have to suction a newborn, just remember the alphabet. M comes before N. You suction the mouth before you suction the nose. Every single time. Why? Because if you suction the nose first, they'll gasp and they could aspirate all those secretions right into their lungs. This is a massive safety point. Okay, let's walk through a case study. You're the nurse, you're assessing a 2-hour-old newborn, and this is what you find. Look at that data. The temp is low. The respiratory and heart rates are high. There's nasal flaring. Put it all together, what is this baby telling you? So, what's your priority action? What do you do first? This baby is screaming cold stress, which is causing respiratory distress. Think about it. A cold baby has to work so hard just to stay warm, burning up oxygen and energy. That's why their heart and lungs are working overtime. So your number one priority is thermoregulation. You have to warm that baby up. Now, get them under a radiant warmer or do skin to skin. Fix the temperature problem, and you'll help fix the breathing problem. And that right there is clinical judgment. Keep asking yourself why, and you'll be well on your way.